Hello, everyone, and welcome to today's Recovery to Practice webinar. I would like to, on behalf of the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, and the Recovery to Practice team, I would like to welcome you all and thank you for joining us today for our third and final webinar in the series on shared decision making. We have over 80 people registered for today's call, on the call so far, and we know this number will go up as we go along. My name is Lori Curtis, and I am your host today. After some brief housekeeping and a short overview of Recovery to Practice, we will begin today's presentation. At the bottom of your screen, you will see a Download Materials box where you can access today's presenters' bios as well as a PDF of the presentation slides and other available materials. This webinar has been pre-approved for continuing education credits from NADAC, the Addiction Professionals Association. To qualify for these education credits, you must attend the full webinar, complete a brief quiz at the end, and the webinar evaluation. You'll get more information on this at the end of the webinar. Finally, if you are a registered attendee, you will be emailed a link to view the webinar in an archived recording. This link will be available soon on SAMHSA's website. This webinar series is hosted by SAMHSA's Recovery to Practice, or RTP, initiative. The overarching goal of this initiative is to improve the knowledge and the ability of the behavioral health workforce to use recovery-oriented practices every day. Understanding what recovery means in this context is critical to our success and yours. SAMHSA's working definition of recovery in behavioral health is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. On the Recovery to Practice website are links to a set of discipline-based curricula to promote the understanding and uptake of recovery principles and practices. Developed by 6 professional disciplines for educating their own memberships about recovery in behavioral health, these materials are adaptable for use by other disciplines as well as organizations seeking resources to build a recovery-oriented workforce. Recovery to Practice also offers free webinars, newsletters, training, and technical assistance opportunities. Check out the Recovery to Practice website regularly or join our mailing list to get information about Recovery to Practice activities delivered to your mailbox. In today's webinar, in this webinar series, we have defined shared decision making. We've considered how it applies to behavioral health. In our last webinar, we recognized that while there are some excellent shared decision making programs in medical and behavioral health care, at its core, shared decision making is a staff competency, along with sets of tools and resources to help support meaningful communication. Shared decision making is something you can practice today. We have also looked at some ways that shared decision making is being integrated into behavioral health care. In our first webinar, we explored shared decision making applications with addiction treatment service. Today, our final webinar of the series, we will look at how shared decision-making approaches can help engage young adults and their families in healthcare conversations. We'll also consider how peer programs can use shared decision-making tools and resources to help people make the most of their visits with providers. And I'd now like to introduce our speakers for today. Our first speaker is Iruma Bello, PhD, a licensed psychologist and assistant professor of psychology at the Columbia University Medical Center. She's also the clinical training director for TrackNY New York with the Center for Practice Innovations of the New York State Psychiatric Institute. Our second speaker is Melody Reefer, MSW, a Senior Program Manager at Advocates for Human Potential. Melody is a longtime advocate and trainer in recovery-oriented practices and in shared decision-making. More in-depth bios for each of our presenters can be found in the Download Materials box. I am going to now turn over the webinar to Iruma. Iruma?
Thank you. So I'm just starting my webcam.
Okay. There she is.
Okay. Hi, everyone, and welcome. Thank you for joining. And my part of this webinar, I'm going to be speaking to you for about half an hour and really discussing how we use shared decision-making within On-Track New York. We'll have no real disclosures to make. And these are some of the things we're going to be covering today. We're going to provide an overview of what On-Track New York is, discuss how we use and introduce shared decision-making to young people and the families that we work with. I'm going to highlight some of the challenges that we encounter, that our teams encounter, as well as discuss and show you some of the tools and resources that we have, and then end with an example of shared decision-making in one of our case examples from one of our teams. So let's start by discussing On-Track New York and what it is. And On-Track New York is a program funded by the New York State Office of Mental Health, and it's really designed to provide early intervention services to individuals experiencing a first episode of psychosis. And a first episode of psychosis, we define it as a mental health condition that's really characterized by symptoms such as unusual thoughts and behaviors, hearing or seeing things that other people don't, or even disorganized thinking and withdrawal from friends and family. And people experience first episode early on. It really starts between the ages of, the folks that we serve are between the ages of 16 and 30. And it's really at the first, when the first symptoms arise that they are eligible for an on-track team. We know that if left untreated, these psychotic symptoms become worse over time. So for young people experiencing a first episode of psychosis, getting the right kind of treatment as early as possible can make a really big difference. So On-Track New York is an example of coordinated specialty care program, and there are several of these coordinated specialty care programs that are being implemented across the U.S. And the coordinated specialty care is informed by research which was funded by the NIMH. And what it really found was that these studies found that people that are enrolled in coordinated specialty care, when they first develop psychotic symptoms, tend to do better across time. They have better outcomes. So in general, a CSC team or a coordinated specialty care team is defined by a very specific framework and key care processes and service components. And we're going to discuss what these are. But it's focused on enhanced collaboration among team members. The team meets together with the young person and the family, and the staff really manages a small caseload. Clients and staff caseload ranges from 10 to 20 to 1, something in that range typically. And the CSC programs provide time-limited and phased care, meaning that many programs provide treatment for about 2 years, or an average of 2 years. So the way that we market On-Track New York, we think of it as an early intervention program for adolescents and young adults who recently have had unusual thoughts and behaviors, who start hearing or seeing things that others don't. And it helps people achieve their goals for school, work, and relationships. So the idea is that when we treat these people and we work with them really closely, we're really focusing on their goals rather than their symptoms of psychosis. So what are some of the interventions that an On-Track New York team delivers? We think of it as a suite of evidence-based practices. And what that means is that there's evidence-based pharmacology, supported employment and education, CBT type of interventions, meaning recovery skills, social skills training, supportive psychotherapy and case management, family support and education, and then suicide prevention. And all of these evidence-based practices, which we know there's research to sort of show that people that receive these provide good outcomes. In On-Track New York, we deliver them using, as I mentioned, a team-based model with a lot of assertive outreach and engagement, also a peer support component, and under the umbrella of shared decision making. And then the idea is that if we, I think there's an audio problem, so I'm sorry to pause, but let me just make sure that. Is this better? Okay, so the idea then becomes that folks can receive this intervention with a lot of outreach, a lot of engagement, and then some shared decision making. And shared decision making is one of the frameworks that really goes through all of these processes. So when we're delivering any of these interventions, we are using shared decision making in hopes of getting people to achieve recovery or engage in a recovery journey. So some of the guiding principles or clinical concepts that drive the On-Track New York interventions, as I mentioned, are a focus on recovery, a focus on person-centered care, shared decision-making, and cultural competency. So we think that in general, when people are delivering these interventions as part of the team, they're really focused on and are able to do all of these things. So let me just take a second to describe some of these in more detail. So when we're talking about doing these things, there's really no steps. These are some underlying principles, and none of them stand alone. They all inform each other. And the hope is that the team strives to really convey a sense of hope and that recovery is something that is attainable and shapes the views of the person with the diagnosis as well as the family, because we really think that the client becomes a central piece of the team. The idea is that we know that people benefit from actively collaborating with their providers, and the goal becomes focusing on people's goals, aspirations, and ambitions, and this is what drives the treatment planning. So when we think of shared decision-making as a principle of the On-Track New York model, we think that it's a collaborative process where people and their providers collaborate to make healthcare decisions, and they take into account the best scientific evidence as well as the person's values and their preferences. So shared decision-making can benefit both the client and the treatment team. We know that when people engage in shared decision-making, they have improved quality of decisions. It increases the client's level of satisfaction. It solidifies treatment alliance. It enhances knowledge and health conditions. And it really contributes to a greater treatment adherence. And then finally, cultural competence, we think refers to the client's awareness, the clinician's awareness of the young person's cultural background and identity, and it can provide an interpretive framework for understanding the symptoms and what's going on. So once again, all of these principles guide the process for how the teams deliver all of the interventions. So another thing that's important to keep in mind with young people is how we think of recovery and how do we think of shared decision making. And Pat Vegan does a lot of work with our group, and she helps us develop all of these materials. So all of this is really a huge credit to Pat, all the tools that we have that I'm going to talk about. But she kind of likes to think about and presents to our teams this idea of the continuum between duty to care and dignity of risk, and then overprotect versus neglect. And really what we mean by that is that there's a duty to care, which means that the team remains engaged with people no matter what decisions they're making. And at the same time, folks have a dignity of risk, meaning that they have the right to make their own choices, to fail, to take risks. And the team has to think through how their interventions or how they relate to the client really falls within a continuum of being either overprotective, which we know is not really helpful for people, or being neglectful, which means letting people sort of do what they want and not providing support. So we try to balance these two poles, the idea of staying sort of in the middle between overprotection and neglect, so that it really allows people to really take some risks and figure out what they want to do and how they want to approach the life decisions that they're making while they're on On-Track New York. So how do we do shared decision making? When we do On-Track New York, part of the intervention is a series of core sessions. And what these core sessions are very specific pieces of information, pieces of interventions and delivery of psychoeducation, and getting the team to understand where that young person and their family is coming from. And how we do that is through these 10 core sessions that we think everyone receives when they're part of the On Track New York team. So we really think that everyone receives information on early intervention and recovery and psychoeducation. Another core session is thinking through what is the person's cultural background, what are their choices, how do they think about where they sit, not only in terms of race and ethnicity, but in terms of being a young adult, what roles do they play within their family and in general in their life. And then we have a core session that really focuses on shared decision making. We also have core sessions on personal strengths. We introduce everyone to the team. And then so forth. So we have these other ones on very specific issues that people might be encountering, like do they need social skills training, do they need substance use treatment, etc. But given that the focus of this webinar is shared decision making, I'm going to just focus on that one core session. And we really start by setting expectations with the clients and their family. So at the beginning, we are setting that stage that the team is going to expect the young person to be an active participant in making decisions. That the expectation is that the young person tell the team what decisions they need to be facing and what is the information that they need to know. So for example, it could be decisions around medication, but it could also be decisions around returning to school or work, which is a big goal for a lot of the young people that we work with. It could be decisions around where they are in the program and how to move forward within the program. Who do they want to work with on the team? Things like that. So the decisions, there's really a wide range, and we want to encourage our young people and our families to bring these to the table to really be able to discuss with the team. Then the second step is letting young people know that the team will help them understand the options that they have available. And then once the young person learns about the options, there's going to be a process, a very systematic process where the team will help people make their decisions. So when we think of shared decision making and we explain it to our young people, we really focus on what is shared decision making. It's a kind of informed consent process, and it's the best kind because we move from what are people's initial preferences, based on their values, based on whatever thoughts they have about their life and the world, to informed preferences, meaning that we're giving them information to help support these different decision points. What do we know? What is the evidence out there? It acknowledges that there's two experts in the room, the person receiving the service and then the person providing the service. And finally, it really helps to clarify an individual's values and preferences for decision making. So it goes from very specific steps to help people walk through making decisions. The first step is what we call choice talk. So making sure that people know that there are reasonable options, that there's a lot of options out there and what these are. And then as providers, we really think through what are the details, what are the information that people need, what are some of the options that we can give them and what information in a way that they can actually use it. So staying away from jargon, what is the evidence out there? And then using decision talk where we actually go through a process of considering preferences. What are the pros and cons around each of the decision points? What are people's values? What do they think would be a best fit based on what their goals are? And then everybody getting on board with that decision to be able to move forward. So why don't we do a polling question? And if you can, if you guys see the poll, if you can just submit your answers and then we can discuss them. Okay. So I think answers are still coming in. Can you guys see that the answers to I guess, to the poll? Okay, great. So then it's everybody can see this, and it seems that the majority of people agree that shared decision making really helps people feel respected because they have a voice and a choice in their care. And that's absolutely right. People want to be involved in these decisions. People feel empowered when you involve them, and the idea is that there is no black and white decision that's right for everyone or that helps people across the board. So it's really important to figure out and let people have a voice and understand all the range of evidence that we have for the different decisions. Okay, so thank you for participating in the poll. And now let's talk about, so now that we know what shared decision making is and how we think about it in On Track New York, and we do this at the beginning. We try to do this as early as possible when people start in our program. I feel like people are having issues with the audio, but I'm not sure. If the tech folks can tell me, okay. The way that we do it is we train our teams to feel really comfortable doing this, but to do it in a very systematic way. At the same time, we still encounter challenges when we try to do shared decision making. And although these challenges are very relevant to our young people, I think that they're relevant across populations. The idea is we work closely with young people and their families, and sometimes combining the client's preferences and their needs and the decisions that they think that they want to make might change or might be different from what their family really wants, and that's a challenge, getting everybody on board. There's also sometimes when young people have psychosis, they're not as engaged, they may not be as assertive, and that also affects the shared decision-making process, and our teams work really hard to try to troubleshoot around this. There's also a sense of invisibility that young people sometimes have. As you know, developmentally it's appropriate for young people to want to take risks, to feel like they're the exception to the rule or what applies to them does not necessarily apply to the rest. So giving advice, or sometimes even when you go through the pros and cons around decisions, it can be actually quite difficult when young people feel like the rules don't apply to them. So that's even more of it's a challenge, but it's also like a big indicator of why it's important to involve people and to let them sort of take ownership around the process. The other piece, and remember we were talking about the duty to care and the dignity of risk, is the ability for clinicians to tolerate risk, particularly in the beginning. So what we have noticed is that as people become more comfortable doing work with first episode psychosis and they actually develop more skills and work more closely with young people, their ability to tolerate risk-taking they develop a higher ability to tolerate risks. So it gets better, but in the beginning it's actually a little bit challenging. Then there's how we think about motivational interviewing, which means that we're trying to change behaviors, versus shared decision making, which is before motivational interview, when we're trying to help people figure out what are the best decisions for them. So for example, you would use something like motivational interviewing for substance use treatment, but you would use shared decision making around decisions about going back to school, or which really it's up to that young person and their family and whatever values they have around this. We also know that there's limits around our medications. We know that for psychosis there isn't one medication that works the best for everyone. So it's important to really have detailed discussions with young people around the medications, the pros and cons, the side effects, so that they can make a decision about what they're willing to, which avenue they're willing to explore. And then finally, the limits of our data. Even though we know certain things work, we don't know what works for everyone. We know things in aggregate. We don't know things for the individual. So shared decision making really allows us to get to know and work with people very closely on things that work for them specifically. So now I'm going to share some tools with you. that are available in a public domain, so you can actually access these. And as I said, Pat Deegan, who is a psychologist and does a lot of work on shared decision-making and recovery, and she works very closely with our team, she's developed a 6-part series for our teams that guide them through how to think about shared decision-making and how to deliver this information. So the idea is that the 6th chapter, which is actually really important, is geared towards clients and families. So this is something you can even show to clients and families so that they can watch. And we tell them to watch it early in our team so that they know how to sort of relate to the team and what the expectations are going to be. As you can imagine, young people in general don't come in knowing how to engage with mental health services when this is their first episode of psychosis. So this sort of is a nice way to set the stage on setting expectations and getting them to change their frame, that they're not going to be passive recipients of care, but instead that they're going to be able to be and expected to be active participants in the process. Okay, the other one that we have, and we have several of these tools, so this one can actually be found in our OnTrack New York manuals. And for this one, it's an aid where we help clients think through what are some of the symptoms that they're having, what are some of their concerns in general, and then they can bring this back to the team to have more detailed discussions. So the idea is that somebody might come in, they might not know exactly what to focus on, or they might have a lot of concerns, a lot of issues going on, and to expect someone to be able to kind of off the cuff be able to talk about these things in a session might be quite difficult. So one thing that our team might do is give them this handout and say, well, why don't you think about this, and why don't you sort of prioritize what's important for you? What are some of your values? What are some of your thoughts around some of these things that are going on with you? And then that really sets the stage for being able to kind of talk about what are the different choices, what to focus on, and then how to think about what are some of the pros and cons. So we have a lot of decision aids that we give to people when they're part of our program, which set the stage for doing really good shared decision making. We have this other one very specifically tied around medications, for example. So this is something that allows young people to highlight how they see themselves and the things that are important for them, which may not be on sort of the team's radar immediately. They may not be things that the team is paying attention to, and yet we know that if we can get on the same page and find some common ground with young people around what is important to them, then they're more likely to make treatment decisions that they stick with and that they feel better about. So with regards to meds, we'll have decision aids like this that can help the process. So now I want to share some data with you from the RAISE projects. Remember that I discussed that OnTrack New York comes from RAISE, which were some projects that were funded, some research projects that were funded for the NIMH. And we collected some data, and we wanted to see how did we know that people that were involved in RAISE felt that the team was doing some shared decision making and doing really good shared decision making. So we did a qualitative study, and we asked people, so when you and your team have talked about your treatment, how much do you feel that decisions about your treatment were joint decisions between you and your team? Because to us, that would be an indication that shared decision making is being done. And as you can see in this graph, we have that most people, so over 50% felt that it was done a lot, a little bit more felt that it was a moderate amount, and a little bit felt that it was a little. So for the majority, people felt very much involved in the decisions that the treatment team was making along with them. And if you can see, you know, a very small, less than 5%, felt that they weren't involved at all. Similarly, we asked people, in the past month, how much did you and your connection team pay attention to your preferences regarding work and school? So not how much did your team think this was important, but paid attention to what the client's preferences were. And once again, you can see on this table that for the most part, people thought that the team was really paying attention to their preferences and what they wanted to do in supporting their preferences. Here we have, when you meet with your connection psychiatrist, how often does your psychiatrist involve you in decisions around which medications to take? And similarly, people feel very much involved around their medications, and which once again speaks to the idea that even the prescribers are hearing people's perspective, hearing what they like, what they don't like, and then figuring out what next steps to take around medications based on this. So now for this last piece, I'm going to discuss a case example of how it might play out in an on-track team. So as you know, we see young people. So this is Tom. He's a 24-year-old man who was recently referred to an on-track New York team following a first hospitalization for psychosis. Some of his goals are to work with a supported education and employment specialist to return to school. At the same time, his parents don't think that he's ready. They think that he should stay home and make sure that his symptoms improve before he engages in schoolwork. So this is a typical scenario, and we would think very clearly on, okay, so how do you approach shared decision-making with Tom and his family, given that everybody has a different idea around how to approach this problem or what they think should be addressed. And now I'm going to give you some tips. So the first part is discussing options and preferences with Tom and his family. So this would include the team, this would include Tom, this would include whoever Tom identifies as his family. It might be, you know, mom, dad, siblings. It could even include friends, girlfriends, whoever would be important social support for Tom. And together, everyone would discuss the different options. So what are the options? The options are to go back to school or not to go back to school. But there's actually a lot more options than that. There's what school, when to go back. So within our teams, for example, people might go to mainstream school, or they might decide to go to homeschool, or they might decide to do something online, or they might decide to even switch schools if they feel like, you know, it's a better fit. And then really weighing the pros and cons in a very detailed way. So what are the choices? And what are some of the options? So what about transportation? What about finances? What about how would med support this or not support this? What could the team offer? So for example, for somebody wanting to go back to school, the family might believe we don't want them to go back to school because, you know, their symptoms might interfere. If it's a school that they're paying for, like college, like they don't want to pay for tuition maybe, and have this be, you know, too much money and have the person fail out. So our team then would kind of delineate. Well, we would help with follow-along supports. We would help people really think through how they might engage in school and how our team would give them support. So we take it away from the black and white of yes school, no school, to a very detailed discussion around this. And then coming up with a plan around, okay, what is the decision that everybody's going to be on board with, and what are the steps for implementing this? And that's how we stay away from the extremes of overprotect and neglect, and we really allow people to take risks, but with a lot of support from the team around their decision. So that is the end of my piece of it, and I'm happy to answer questions, but I think now we'll send it, we'll transfer it over to Melody, who's going to be presenting the second part of the webinar. Thank you.
Thank you so much. Excuse me. Give me just 1 second. It's great to spend some time with you all this afternoon. And when I saw the information that Aruma was going to be sharing, I was really excited about it, because I think that if we can improve the quality of services that are presented to people early on as they're trying to gain mastery over any type of psychiatric symptoms that they're experiencing, the better off they'll be, which is an obvious thing, but the better off the system will be, that we'll be able to make sure that folks get a good start and a deeply grounded foundation for their recovery throughout their life. And the interventions that on track and the things that are being learned through the RAISE project with the National Institute of Mental Health are just really groundbreaking. And so I hope y'all enjoyed that information as much as I did. But I want to take a little bit of a different spin and talk about the way peer providers are involved in the shared decision-making process. And there are a number of things that we have to consider when we head in that direction. So the first thing is, how do we even define peer? And that is differs depending on who you talk to. So certainly, you know, in common vernacular, you know, the way the whole world defines peer is that it's a person who is an equal in life experience or in station in life. And so, you know, people globally have an idea what a peer is. A lot of times we think about it as a classmate, or peer is used within the context of peer pressure. But whereas people who are alike have some sort of interaction. And so when we talk about peer within the behavioral health world, that same level of information or that same level of understanding is communicated, but there's a bit more to it than that. So there we look at peer supporters who are, as you see in this definition, people with a personal experience of recovery from a mental health, substance abuse, or trauma condition, who have received specialized training and supervision to guide and support others who are experiencing similar mental health, substance abuse, or trauma issues toward increased wellness. And so this definition comes from the International Association of Peer Specialists, and it captures a different level of what peer is. We also then look at what is it that peer providers do. And so peer providers do a number of things, and you see some of those listed here in bullet points. I won't read the whole list to you, but I do want to point out that the main thing that peer providers do is carry forward the message of recovery. In the behavioral health world, we haven't always talked about recovery, and in fact, we've frequently talked about the opposite of recovery, and that is that, you know, mental illness is a lifelong disorder, that you'll have it for the rest of your life, that it will limit your options and capacity, but we know that those things are not true, and so as we have had more research to believe what we've always known anecdotally, it's created this opportunity for people who have a personal experience with recovery to come into where services are provided and say, hey, you know, this is not all gloom and doom. You can have the life that you have always hoped for. And there are things that you can do to help increase the odds of that. And those are then the things that peer providers do. So providing support when people are in crisis, or helping people learn how to navigate systems, or helping people connect with the right professionals, that then becomes the focus of the work. We also know that of all of those things that happen, it's important to note that the support that's provided to people includes all types of conditions. And so peer work doesn't just live in a particular place. In fact, the whole idea of the impact of peer support existed long before there were any kind of certification processes or trainings or billable activities for people called peer specialists. In fact, peer providers, as we look at it as an organic process, are friends, are people who step up and step into people's lives and help people move towards wellness. And so peer supporters now in a formal way can be in mental health centers and inpatient settings, outpatient settings, in jails, in respite programs, run programs that are completely and 100% led by and created by people with the experience of recovery. And then even with that, developing specialties where either through specific life experience or specific additional training offer information to folks. So we also find that there's great concordance between the principles of shared decision-making, which Aruma already spoke to, and the principles of peer support. Glenn Elwyn has written, the skills of shared decision-making are unlikely to be developed, let alone exhibited, unless the clinician agrees with the guiding ethical principles. At its core, shared decision-making rests on accepting that individual self-determination is as desirable a goal and that clinicians need to support patients to achieve this goal wherever possible. And peer specialists and peer supporters are able to deliver that type of care and that type of interaction with people. And so it's important that even in systems where there has not been a adoption of shared decision-making, peers can teach other peers about shared decision-making, and the person can begin to advocate that that level of care or that type of care become the model for the services that they receive. So in some ways, peer providers can be the Trojan horse and carry in this message to help people spread the word about shared decision-making. There are 6 core elements of activation, and activation is the secret sauce to recovery. And so these elements are really important, and these are the things that should drive how we look at the activities that we advocate for in shared decision-making. Things like symptom self-management, engagement in activities that support health and wellness. And number 3, obviously, involvement in treatment decision-making. Collaboration with healthcare providers, critical performance-based selection of providers, and navigation of the provider system. So having this input helps people be connected to their services. And so just real quickly, a couple of examples. Pat Deegan, who's already been alluded to, created a software program that helps people engage in shared decision-making. But it not only helps the person prepare for shared decision-making, it also helps the provider prepare. So both people benefit from this approach because it provides a little bit of behavioral tailoring to help keep folks focused on what they're looking for in an outcome. And then another example, and this one's really exciting because it was a peer-run program that said we're going to study and learn about shared decision-making in peer services and have our whole recovery center work from that principle. So the Recovery Center of Hamilton County, which is in Cincinnati, Ohio, set about to learn what they could about shared decision making. And the way they did that was they joined a brass tacks shared decision making community. So brass tacks is another psychiatric advance directive. Is another SAMHSA initiative that focuses on recovery, and it authored a virtual learning community and a collaborative learning community, which were virtual trainings that people could attend to learn deeply about shared decision making, and then put that practice, get that practice going and work together in teams to benefit each other. And so in this program, they trained peer staff and members. They completed a demonstration project that led to the implementation of shared decision making, and it added an increased skill set for the folks who were certified peer specialists, so that they had an even deeper wealth of knowledge that they could share. So our vision for shared decision making and their vision is to empower individuals to make more informed decisions with providers through education and peer support. And we can help realize that vision by making sure that on a national level, peer providers, by any other name, whatever you call them, get exposed to and learn about shared decision making. That shared decision making is wrapped into the curriculum that's used around the country for certification processes, that Medicaid can be used to incentivize shared decision making, that we develop decision aids that are easy to use and available to peer providers, and to educate people to expect, request, and participate in shared decision making. There are a number of resources and readings that I would highly recommend. As you wrap up your summer, you might want to print some of these out and read them while you're at the lake or the ocean. It'll do you some good. But at this point, I'm going to turn this over to Lori, who will lead us in our comments and questions. Thank you all very much.
Hey everybody. Thank you so much, Iruma and Melody, for your presentations. I was a little delayed because there's been a very active chat this afternoon, and that's always delightful because people are taking on what you're saying and they're thinking about it. And a couple of questions have been raised that I'd like to share with you. I think one of the most powerful issues that actually, to me anyway, that came out in the chat, and I'm going to start with you, Iruma, and that is one of the attendees was saying that people employees at her organization would be a little scared of shared decision making because they would worry that that people would choose to not take medications, that would be part of it. So basically, and in your presentation, you started with shared decision making about whether or which medication people would take, but the fear is that it would turn into a whether to take medication. How do you handle some of those concerns within OnTrack New York?
That's a really great question. And when we think of OnTrack New York, medications are not mandatory to participate in OnTrack New York. So we really start from the premise that it is people's choice. And yet we find that, I think if I'm quoting the data correctly, I think about 80% of our OnTrack New York participants are taking medication. Because the idea is that by presenting it as a choice, and then having a very detailed discussion around what are some of the concerns, and if a prescriber can address those concerns and get on the same page with the young person and the family, then it doesn't become this I take medication or I don't. It becomes I'm taking something that's helpful for me. I'm taking something that's relevant for achieving my goals. You tie it to something that's bigger, and then people are on board. So you're right, it's a fear, but I think we do a lot of training with our teams to not get stuck in that black or white mentality.
Melody, do you want to add to that? I bet you're chomping at the bit to add to that.
Yeah, I am. I mean, I think that's absolutely correct, what Aruma has said. And it's much more meaningful to have an honest conversation about using medication or not than it is to just have somebody say yes and then go off and not take the medicine, which we know happens. And so if these can be, if there can be transparency, and if we can talk about, what's beneficial and where are the risks, and to really, make a better informed decision, then I think that people are able to, even if they decide not to take medicine, pull in other resources that can help support them to a greater extent, maybe in lieu of medicine.
Great. The other another question that came up is a little bit more discussion from you to start, Aruma, on dealing with the differences of opinion between a young adult and a family member. That can be highly contentious. And one of the participants asked about how does that work with guardians, particularly if the guardian isn't agreeing with the decision that perhaps the young adult and a clinician may be making. So can you deal with this conflict issue with the third-party parents and guardians?
Yeah, I mean, I think that there is an added complexity when you're working with parents for people under 18. And once again, I think it's a similar answer. You try to stay away from the black and white of it, of what's one person's opinion versus another person's opinion, and let's battle it out. And instead, to really figure out what are the underlying concerns. Why does the young person see it one way? What's behind the guardian's perspective? Sometimes people want to make a decision based out of anxiety, out of not having all the information, and providing some whether it's psychoeducation around or providing some scientific evidence around one thing versus another, and giving people an opportunity to think it through and flesh it out, and bringing it all to the table, the young person's perspective as well as the family's perspective, helps demystify that decision and helps people get on the same page and be willing to at least try it out, because that's all we're asking for when we're doing shared decision making. Let's take that first step and all of us be together on that first step. We don't have to stick with it if it doesn't work.
Okay. Melody, you want to add to that?
Yeah. I think that there's kind of an answer for or an approach for when somebody is underage, but when somebody is an adult, it gets a bit more complicated because you have to address whether or not the person is a legal guardian, be that a parent or someone who's assigned to that role, or is it a concerned family member? And then the approaches are different in terms of who kind of has the final word. But there's been some recent research around shared decision-making within a triad or greater. So usually shared decision-making has been framed as something that takes place between two people. But when you add in another opinion or several other opinions, it of course gets more complicated. The goal, of course, is, again, just like Aruma said, to avoid the edges and to move into more transparency. So it's not an either or black and white, but moving into why does somebody feel the way they do? Shared decision-making isn't about making a decision and sharing it from whatever place you're sitting. It's really about everybody contributing from their expertise and coming up with what's the best solution, and knowing that you can then make another decision. So you may try something on to see how it fits, and that's part of the decision. And in that way, you keep the conversation moving forward. And to me, that's the strength of shared decision making. It's always moving forward.
I think you make an excellent point, Melody, and I think one of the things that's exciting, and I think you both, Iruma and you, Melody, have alluded to it, is that the kinds of decisions we're talking about making here are revisitable. In other words, they're not dead-end crossroads. This is it. This is the way it needs to be forever. You know, we are thinking, the decision we're making is largely, what is our next step? And can we try this out? How do we know it's working? How do we know it's not working? How do we know things are getting better? How do we know things are staying the same or getting worse? And that becomes the focus of the kind of shared decision-making that you are both talking about. And it sounds to me very much that that's a pivotal element in any shared decision-making, but especially important with working with young adults.
Absolutely.
All right, and with that, I'm afraid we need to close off for this afternoon. We have had a very, very interesting webinar, and I certainly appreciate both Iruma and Melody your spending time with us talking about shared decision-making, your experiences, and some of the training that you have provided. If anyone would like more information from either Iruma or Melody, please do not hesitate to contact them. Here are their emails, and you can also contact Recovery to Practice directly, me or any of our team at the Recovery to Practice email below. We are also excited to let you know about some webinars that are coming up. We are in the process of developing our webinar series for next year, and we would certainly love it if you would email to us at recovery or RTP at ahpnet.com and let us know what you would like to see from Recovery to Practice webinars. We are very interested in hearing from you. We would also like you to know that we have a webinar coming up on October 4 on psychiatric advance directives. If you are on the Recovery to Practice mailing list, you will get information about that webinar. Please register and join us. If you are interested in NADAC continuing education hours, please click here where you will be directed to a page with an evaluation and a quiz to complete for your certificate. If you do not need NADAC hours, you can download a certificate of participation for this webinar as well as the presentation slides in the download materials box near the bottom of your screen. Please, everyone, be sure to complete the feedback questions that will automatically load onto your computer when we have completed the webinar. We really do value your input and find it extremely helpful as we develop materials for next year. So on behalf of SAMHSA, I would like to thank you all for taking the time out of your day to attend today's webinar. This concludes our call for this afternoon, and please have a great afternoon. Take care. Bye-bye.
Thank you.